everybody, this is Dr. Chitra here, your mentor at Study EFOG. And in today's video, we are going to be seeing important charts and flow charts for venous thromboembolism and cardiac disease. So you have this 36-year-old, gravida 5, para 4, previous normal vaginal deliveries. She has come for her booking visit. No comorbidities, BMI is on the higher side, 31, non-smoker. So what would be her VTE score assessment? Now the options are 1, 2, 3, 4, and 5. The answer here is her score is 3. Okay. So you would be wondering, how did I come to this score of 3? So remember that there is a very good chart provided in which all the risk factors have been given. And these are all pre-existing risk factors. And from here, you can calculate what is the risk of this woman developing thromboembolism in pregnancy. And depending on what is the total, then you can decide the time when you want to start for her thromboprophylaxis in pregnancy. Okay. So whenever there is history of previous thromboembolism, except single event related to major surgery, that means unprovoked or estrogen provoked, these are very high risk factors and the score is 4. Okay. Whenever there is VTE provoked by major surgery, it is a score of 3. If it is a known high risk thrombophilia, it is a score of 3. Some medical comorbidities like cancer, heart failure, active systemic lupus erythematosus, then inflammatory polyarthropathy, inflammatory bowel disease, sickle cell disease, nephrotic syndrome, type 1 diabetes with nephropathy, or current intravenous drug use. All these are a score of 3. And if there are some other risk factors, these are low risk factors. For example, age, very common, more than 35. Obesity, that means BMI of more than 30. But there is a catch here. Anyone with a BMI of more than or equal to 40, her score is 2. Then parity, more than or equal to 3. Those who are smokers, those who have gross varicose veins, or family history of unprovoked or estrogen-related venous thromboembolism in first degree relative. Or if there is a known low-risk thrombophilia but no VTE, then all these are a score of 1. So it's very important for you to remember this chart. It should go on your study wall and read it at least once in a day. Now, similarly, there could be some transient risk factors. This woman, 35 years old, she is undergoing IVF treatment and she developed ovarian hyperstimulation. So the treatment was successful. She's now 6 weeks pregnant. What is her VTE score? Remember, OHSS is a transient condition. At the end of first trimester, OHSS is supposed to resolve. So any transient risk factors like OHSS, only the first trimester, it is a score of 4. Any surgical procedure done in pregnancy or in the puerperium, except immediate repair of the perineum. Okay, that means suturing of an episiotomy. That is not considered to be a high risk factor. So emergency appendicectomy done either in the antenatal period or postpartum period, or postpartum sterilization. Hyperemesis. These are transient risk factors. So they have a score of 3. And then current systemic infection or immobility, dehydration. All these are a score of 1. So these are other various risk factors that you should be aware of and what is the score for them. Now let us see for how long will you give thromboprophylaxis. Okay. So a 28-year-old woman, BMI 25, she has come into the antenatal clinic at 12 weeks. 2 years ago, she had confirmed unprovoked iliofemoral thrombosis in her left leg. So it's very important to know whether it is unprovoked or is it due to some surgical procedure. So if it is unprovoked or it is estrogen dependent, remember it is a very high risk factor. So it has a score of 4. So what would be your advice for thromboprophylaxis in this pregnancy? Now remember, this is a very high risk thrombophilia. This is a very high risk factor. So you will give her throughout pregnancy and for 6 weeks postpartum. Okay. she has already come to you at 12 weeks. That means the first trimester is about to finish. So you can start immediately. And the postpartum period is a very high risk period. So at that time, definitely for a period of 6 weeks. Okay. Now you have another lady, similar, but she had confirmed iliofemoral thrombosis in her left leg after major knee surgery. So this is because of surgery. Now here, this thrombosis due to a surgery has a score of 3. Okay. So for them, you will start for them from 28 weeks in the antenatal period, but you will continue for 6 weeks postpartum, because the postpartum period is supposed to be the highest time or the period when we will have thromboembolism. Okay. Now you have this 24-year-old woman. She is 12 weeks pregnant and she has confirmed venous thromboembolism in this pregnancy. So for her now, she already has in this pregnancy. So she needs treatment for that. So for treatment of thromboembolism, you will give her the therapeutic dose of low molecular weight heparin. And remember that in pregnancy, there is a very high chance of recurrence. So the therapeutic dose is continued for the entire duration of pregnancy. And you will also continue it in the postpartum period. Okay, at least 6 weeks postnatally. And the total duration of treatment should be at least 3 months of total duration of treatment given. Now, the next important thing is, when will you start thromboprophylaxis in pregnancy? You will start whenever the woman presents to you, or will you give for like a score of 1 or 2 or 3? You will give in the full antenatal period, like starting from the first trimester in pregnancy, or would you want to give in the second trimester or the third trimester? So there are specific guidelines for that. When the score is more than or 4 antenatally, you will consider thromboprophylaxis from the first trimester. If the score is 3, you will consider from 28 weeks. And postnatally, if the score is more than or equal to 2, you will give at least for a period of 10 days. Okay. Any woman admitted to the hospital for a period of more than or equal to 3 days, or she is readmitted to the hospital in the puerperium, at that time you will consider thromboprophylaxis for her. But always keep one thing in mind: any woman who has an identified bleeding risk, you have to balance the risk of thrombosis and bleeding, and always discuss this with the hematologist and then prepare a thromboprophylaxis plan for her. Now, another question is, when will you stop low molecular weight heparin? So you have this woman, she had an episode of pulmonary embolism at 32 weeks of her pregnancy. She is on a therapeutic dose of low molecular weight heparin, and she is posted for an elective cesarean section at 39 weeks of pregnancy. Today, in the morning at 10 o'clock, 10 a.m., she has taken her last dose of therapeutic low molecular weight heparin. What is the safe time for her to undergo a regional anesthetic for the surgery? Whether it is 12 hours or 24 hours or at any time 4 hours after the last injection, you would be given various options for that. Remember, there are specific guidelines for this also. Okay. So regional techniques should be avoided at least 12 hours after the previous prophylactic dose. Okay. And 24 hours after the therapeutic dose. Now, if a woman has undergone an LCS and she has been given a spinal anesthetic, then that means low molecular weight heparin, the therapy prophylactic dose should not be given for 4 hours after the spinal anesthesia or after the epidural catheter has been removed. Now, any woman who is supposing on an epidural for pain relief, once the dose of low molecular weight heparin has been given, you will not remove the catheter for a period of 12 hours after the most recent injection. Okay. Now, there are some women who are at a very high risk of hemorrhage, but they are also, they are at very high risk of developing thrombosis in pregnancy. So in the immediate postpartum period, you could use some mechanical devices for them to prevent thrombosis. So these could be, you could be using anti-embolism stockings or foot impulse devices, or you could use intermittent pneumatic compression devices. Or sometimes those who are at a very high risk of developing postpartum thrombosis, you can use unfractionated heparin for those. Okay, why? Because unfractionated heparin has a very short half-life, and if the woman develops a hemorrhagic problem, you can immediately stop the infusion of unfractionated heparin, and there would be no risk of further hemorrhage for her. Okay. Okay. You have this 28-year-old woman with antiphospholipid syndrome. She has a history of previous thromboembolism while she was on the oral contraceptive pills. That means she has estrogen provoked thrombosis. She's planning to conceive and she wants your advice. Now, remember, pregnancy alone again is a period of high estrogen, and she already has had one episode of thromboembolism due to estrogen. So, definitely, she would be needing some sort of thromboprophylaxis during pregnancy. What would your option, what would be your answer for her? So, remember, because it is a very high risk situation, you will give her high dose of low molecular weight heparin antenatally. That means the high therapeutic dose in either 100% or 75%. And you will continue it for a period of 6 weeks in the postpartum period. Okay. Now, other sort of questions would be like, you have this woman who is pregnant, she is traveling, and she presents to A&E with signs and symptoms of pulmonary thromboembolism. Okay. So they want to start low molecular weight heparin for her. They would be giving you her current weight and her booking weight, and you are supposed to calculate what is the dose of low molecular weight heparin she should be receiving. Remember one thing, whenever you are calculating the dose of low molecular weight heparin, always keep in mind that it should be the booking weight of the woman and it should not be her current weight. Okay, so there are charts available which tell you, according to the weight of the woman, what would be the dose of low molecular weight heparin that you are giving her. So for this woman, her booking weight is 66 and her current weight is 76. So keeping in mind that her booking weight is 66 here, the dose, and remember, what are you going to give for her? Okay, so you want to give her dalteparin. Okay, her booking weight is 66 kg and you want to give for her therapeutic dose. So what would be the option for her? The correct option is actually 12,000 units. I'm sorry, this is the chart for prophylactic dose of low molecular weight heparin. The therapeutic dose is definitely higher than this. So the therapeutic dose is 6,000 units 2 times daily. So that comes to 12,000 units in a day. Now, though low molecular weight heparin is a very useful drug or a safe drug to be used, there are some contraindications to its use. So you should be using it with caution in those who have no bleeding disorders. There is active antenatal or postpartum bleeding. Then women, those who are at a high risk of major hemorrhage, like those who have placenta previa, women with thrombocytopenia, if they have had a stroke in the previous weeks, if renal function is compromised, or there is severe liver disease or uncontrolled hypertension. So for in these women, you have to use it with caution, or you might even sometimes avoid using it. If you want to use it, you will use it in consultation with a hematologist. Let us see a few SBAs. So these are the options that you have here. You can pause the video, read the questions very carefully, and then answer. So you have this 36-year-old Nali Gravida, BMI of 32, and she has undergone elective CS for breech presentation. Here you have to choose what is the most correct option, appropriate management option for her. She is discharged home on day 2 in the post-operative period. So for her, this woman, she has three risk factors. Okay, her age is 36, her BMI is high 32, and she has undergone an elective CS. So her score is 1. So for her, you would be giving her option F, that is prophylactic for a period of for 10 days in the postpartum period. Okay. Then 36-year-old, she has come with pain in abdomen. She has a triplet pregnancy. So again, here two risk factors again, and she has a VTE 3 years ago, unprovoked. So this woman is at a very high risk. Anyone with an unprovoked VTE presenting. So for her, you will immediately start and you will continue for a period of 6 weeks in the postpartum period. Okay, because forget her 36 years and the triplet pregnancy. She is very high risk because already her score is more. Actually, her score over here is 6. So in the antenatal period and for 6 weeks postpartum. Okay. Another lady, 37 years old, nulli gravida, 20 weeks, low-lying placenta. She underwent a CS, elective CS at 38 weeks for placenta previa, lost 2000 ml blood. She was transfused 1.5 liters of blood, discharged home on day 3, and presented 2 days later with sepsis infected wound, and she was readmitted. So this lady definitely, yes, she is going to be needing in the postpartum period. Now, the thing is that she has been readmitted. Okay, so whenever anyone is readmitted, according to her plan, at least for a period of 10 days, she is going to need. But if she is going to be admitted for a period longer than 10 days, then you will continue for her thromboprophylaxis until she is hospitalized or she has completed 10 days, whichever is later. Okay. You have another para 5, 36 years old, 20 weeks, BMI of 41, and varicose veins. So para 5, 36, and remember BMI 41. Anyone with a BMI of more than or equal to 40, her score is 3. So for this one, again, in the antenatal period and postpartum for 6 weeks. Okay, because her score is like parity, age, and BMI 2. So her score is 4. So immediately in the antenatal period and for 6 weeks postpartum. Okay. Now 31-year-old at 20 weeks, and she has a history of superficial thrombophlebitis 6 months prior to pregnancy. Remember, thrombophlebitis is not an indication to give low molecular weight heparin. If she has gross varicose veins, then yes, her score would have been 1. But superficial thrombophlebitis, it is not an indication. So you will not give low molecular weight heparin for her. Okay. So this is another chart which you should be aware of. Here on the left side, they have given you all the factors, antenatal risk factors, which are high risk. So those who are high risk, they will require in the antenatal period. Those who are intermediate, you will consider for them from 28 weeks of pregnancy. And those who are less than 3 weeks for a less than 3 score in the antenatal period, you will not give them any thromboprophylaxis, but you will just advise mobilization and avoid dehydration. Now remember, the risk assessment again has to be done in the postpartum period. So those who are at a high risk, that means those who have had previous venous thromboembolism, anyone who is taking thromboprophylaxis in the antenatal period, those who have high risk thrombophilia, or there is a low risk thrombophilia, but there is a family history of venous thromboembolism. So the general rule for them is that you will give them for 6 weeks in the postnatal period. Okay. Those who have intermediate risk, for them at least for a period of 10 days. And those who have again low risk factors, for them again at least 10 days. And those who have less than 2 risk factors, for them again you will not give, but you will just advise them early mobilization and avoidance of dehydration. Okay, next coming to management of acute pulmonary embolism in pregnancy. So this is regarding the investigations that you would do for her. So 36-year-old woman, BMI of 38, and she is 32 weeks in her pregnancy, and she has sudden onset of shortness of breath, no cough or chest pain, and she has right leg pain and swelling. Right leg pain and swelling. Her pulse rate is 100, her blood pressure is 110, temperature is normal, respiratory rate is 18. Auscultation of the chest is normal, X-ray chest and ECG are normal. But you suspect, because of her signs and symptoms, that she has a pulmonary embolism, and you start low molecular weight heparin for her because this is a life-saving drug for her. So what is the next appropriate step in her management? They have given a few investigations like CTPA, perfusion scan, arterial blood gases, X-ray chest and ECG, and compression duplex ultrasound of lower limb. So X-ray chest and ECG have already been done and they are normal. Okay. So whenever both of them are normal, but she has signs and symptoms of DVT in her right leg. So remember, any woman presenting with signs and symptoms of pulmonary embolism and she has signs and symptoms of DVT, the next investigation that you would be doing for her is compression duplex ultrasound of the lower limb. We will see why. Because any woman who has signs and symptoms of DVT with suspected pulmonary embolism, you will do a compression duplex ultrasound of the lower limb. If this ultrasound confirms that this woman has deep vein thrombosis, no further investigation is necessary and you will continue treatment for venous thromboembolism. All right. So you have this woman who is 30 weeks pregnant. She is on a long haul flight and she presents to A&E with history of shortness of breath and chest pain. Okay. So which of the following is not appropriate in an investigation of suspected pulmonary embolism in pregnancy? Choices are CTPA, X-ray chest, D-dimer, ECG, and VQ scan. So you will not be doing a D-dimer. Why? Because during pregnancy, as pregnancy advances, the levels of D-dimer rise, okay, as gestation advances. And therefore, they are not of much help in coming to a diagnosis of pulmonary embolism. Okay. So that is why D-dimer test is not done as a diagnostic test for pulmonary embolism. Now, this is the flow chart that you should be aware of. So whenever you have any lady with suspected pulmonary embolism, you will do a clinical assessment, do an X-ray chest and ECG, basic blood tests like a full blood count, use and ease, and liver function tests, and start low molecular weight heparin unless it is contraindicated. Once low molecular weight heparin has been given, you will go back and see the signs and symptoms of DVT. If they are present, you will do a compression duplex ultrasound of the lower limb. If that ultrasound confirms that there is DVT, no further testing is required and you will continue therapeutic dose of low molecular weight heparin. Now, if there are no signs and symptoms of DVT and the ultrasound does not confirm that a DVT is present, you go back to the previous investigation. So go back and see the X-ray chest. Is the X-ray chest normal? If it is normal, you will do a VQ scan. If the chest X-ray is abnormal, you will do a CTPA. Okay. Either of these investigations would either confirm or not confirm that pulmonary embolism is there. If pulmonary embolism is there, you will continue therapeutic dose of low molecular weight heparin. Okay. If X-ray chest and if the VQ scan and CTPA do not confirm that pulmonary embolism is present, but your clinical suspicion is very high, then in those cases, you will continue low molecular weight heparin and you will consider alternative or you will do the tests again. If your clinical suspicion of pulmonary embolism is low, you can discontinue low molecular weight heparin and you can consider some other diagnosis of shortness of breath or chest pain. Okay. So this is another flow chart which is very important, and please go through this flow chart very carefully. Now next, coming to cardiac disease. So these are a few changes that you would see in the ECG of a healthy pregnant woman. Which among these is not a physiological change and can be seen in the ECG of a pregnant woman who presents with acute myocardial infarction? So a left axis shift, ST segment depression, ST segment elevation, T wave inversion in inferior and lateral leads, or a Q wave in lead AVF. So it is ST elevation, which is not a physiological change, and it will definitely be seen in any woman. It can, whenever you see an ST elevation and there are signs and symptoms of acute myocardial infarction, you will know that this is a pathological finding. It is not a physiological finding. Another woman attends the antenatal clinic at 32 weeks gestation, fit and well, no comorbidities. She has a vasovagal fainting episode. ECG at that time was normal. So, which of the following features on an ECG would have prompted suspicion of an underlying abnormality? So, atrial ectopics, right shift in QRS axis, ST segment depression, and T wave inversion in inferior and lateral leads, small Q wave, inverted T wave in lead 3, or ventricular ectopics. So the answer is a right axis shift. Remember, left axis shift is normal in pregnancy. But a right axis shift, it might indicate that there is right ventricular hypertrophy as the right ventricle is enlarged and it generates more electrical activity. So it is very important to know what are the normal ECG findings in pregnancy. So ECG findings of atrial and ventricular ectopics or Q wave and inverted T wave in lead 3, ST segment depression and T wave inversion in inferior and lateral leads, and left axis shift of QRS axis. All these are normal physiological changes. If you see any change other than this, you will know that it is not a physiological finding and it could indicate some underlying pathology. Okay. Now you are seeing patients in the maternal medicine clinic, 5 women with different cardiac conditions, all are primaries, there are no other risk factors. You would be concerned about which lady. So the one with bioprosthetic aortic valve, or the one with mitral regurgitation, aortic regurgitation, mild aortic stenosis, or mechanical prosthetic mitral valve. Remember, women, those with mechanical prosthetic valve, they are at the greatest risk during a pregnancy. Okay? Because regurgitant lesions are better tolerated than stenotic lesions. Bioprosthetic valves do not require anticoagulation, but those with mechanical prosthetic valves, they require anticoagulation, and generally the outcome, like the pregnancy, is very high risk for these women. Okay. So stenotic lesions are not well tolerated, both aortic and mitral. Regurgitant lesions are usually well tolerated, generally well tolerated. Those with prosthetic valves, those who have bioprosthetic valves, there could be accelerated degeneration of the valves. There could be challenges with anticoagulation in these women. And those who have mechanical valves, there is a risk of valve thrombosis. So usually these are the women, those who are at a greatest risk in pregnancy. Okay. Now you have this 25-year-old woman at 7 weeks of gestation. She has a congenital heart disease and she has Eisenmenger syndrome secondary to ventricular septal defect. What would be the most appropriate advice in terms of management for her? Bed rest and home oxygen therapy, commence oral labetalol, commence oral sildenafil, commence thromboprophylaxis with low molecular weight heparin, or termination of pregnancy. So termination of pregnancy is the best option for her because termination of pregnancy, though associated with a mortality of 7%, this is much less than the maternal mortality that is associated in women, those who have Eisenmenger syndrome. If the pregnancy is allowed to progress, the maternal mortality is about 40% for these women. So, women those who have Eisenmenger syndrome, you should always offer them good contraceptive advice. And in case the contraception fails, it is always better to offer a termination for her. Okay. So in Eisenmenger's, what happens basically? There is a reversal of the shunt. So whenever there is atrial septal defect or a ventricular septal defect, because pressures in the left side of the heart are more, blood is shifted from left side of the heart to the right side. But because of this long-standing left to right shunt, that leads to pulmonary hypertension. The pressures in the right side of the heart increase above that of the left side of the heart, and you get reversal of the shunt. So what happens? Blood from the right side of the heart, it is shunted to the left side of the heart. And deoxygenated blood is the blood that is circulated throughout the body. So that is why the woman, she becomes cyanotic. Now, whenever there is Eisenmengerization, so the fetal outcome is very poor because of the low oxygen saturation. There is polycythemia. Maternal mortality is very high, to the risk of 20 to 40%, and the maternal mortality is very high during the puerperal period. Okay, so that is why for these women, it is better to offer them termination of pregnancy, though even with termination of pregnancy, the risk of maternal death is around 7%. Now you have this woman who has a cardiac disease, she says, and she has a rheumatic cardiac disease. And she is telling you that she has been told by her doctor back home that she should be avoiding one of these drugs in the third stage of labor. So benzylpenicillin, ergometrin, oxytocin, either IV or IM, or sodium chloride with potassium chloride. Remember, any woman with a cardiac disease, you will always avoid giving her ergometrin intravenous, because this causes sudden rapid autotransfusion, and the preload to the heart increases, and that can precipitate pulmonary edema. Okay. So, whenever you're answering any questions on cardiac disease and pregnancy, you have to keep a few things in mind. Remember the physiological changes that happen in pregnancy. So, there is a decrease in the vascular resistance. Because of that, the blood pressure rate increases, and the heart rate increases, and also the blood volume increases in pregnancy. We know there is hemodilution, and also the stroke volume increases. The cardiac output increases by 30 to 50%. So, and all these changes, maximum changes, they start at around 8 weeks of pregnancy. Maximum changes are seen at around 28 weeks of pregnancy. Now, during labor, what happens? Because of pain and anxiety, cardiac output increases by about 50 to 60%. During each uterine contraction, 300 to 500 ml of blood is infused into the central venous system. Okay. So during labor or during a uterine contraction, blood volume increases, cardiac output increases, heart rate might increase or decrease, blood pressure increases because the preload and the cardiac output, everything increases, peripheral resistance remains unchanged, and oxygen consumption also increases. Now, in the postpartum period, what happens after delivery? Because the obstruction on the IVC is released. The gravid uterus, we know it causes obstruction to the IVC. So once the woman delivers, this obstruction is released, uterus contracts, and more amount of blood is forced into the circulation. So this increases the cardiac output by 60 to 80%. Also, after delivery, fluid from the extravascular space, it is pushed back into the intravascular space, and that increases the venous return and also the stroke volume. Okay, so because of this, women, those who already have a cardiovascular compromise, they are at a very high risk of going into cardiac failure or having pulmonary edema during the second stage of labor and in the immediate postpartum period. Okay. Once the woman has delivered, the cardiac output, it returns to pre-labor values within an hour of birth. So all these changes are maximum in the first hour after birth. So these were important charts and flow charts or diagrams that are associated with venous thromboembolism and cardiac disease. Thank you for watching the video. I hope you found the video helpful. And good luck to you for all your exams. We are all praying for you and hope that you clear this exam. Thank you for watching the video once again, and have a nice day ahead.